We're waiting for Amy to get on.
Mhm.
She didn't have a link.
Hi, everyone.
Hello. Good morning.
Hey. Hello. Hoping we are enjoying the start to summer. Maybe have a lighter crew today with some folks out. Hi, Rita from the East Coast. Okay, Robbie, give me the heads up on when you would like us to start.
I think we're good to start.
Okay, great. Well, welcome everyone to Connecting for Better Health. And we are really pleased today with our agenda. We are going to hear about a statewide EHR effort from CalMHSA. And we learned about this probably about 6 months ago or so, Robbie. And it just is really interesting innovation. And we want to be able to bring it to you and then think about how the pieces and parts are going to fit together, especially given the data exchange framework and, statewide data exchange. So we'll have that presentation. And then many of you probably tuned in last week to our the advisory group and the data exchange framework. They are on track to release the data sharing agreement this week, July 1st, which is tomorrow. Is it July 1st tomorrow? Mm-hmm. So we're waiting, sitting on our hands on that one. And so Robbie's going to give us a preview of what we heard in the advisory, in the framework discussion. And then we will be doing a one-on-one comparison that we'll be pushing out once that's released, with looking at what our requests were, with our comments, what was accepted, what's still to be done. And then we have some news and events. So like always, if you could please introduce yourself in the chat, especially for those of you who are new, please introduce yourself. This is a great way to help with our networking. And also, if you have any announcements that you'd like us to include either today or in our weekly roundup, please go ahead and throw that into our chat as well. And we will do the follow-up. Let's go to the next slide. I'm seeing some new faces here. Connecting for Better Health is committed to helping advance data sharing across California so that all providers and consumers have access to health data to make better decisions. We also are focused on policy priorities based on where we are with the advancement of data exchange across the state. This year, we're really focused on looking at funding for data exchange and acknowledging, especially for other states that have been down this path before, that there is additional federal funding available, and is the state seeking that federal match and doing what's necessary to be able to bring the investment needed to be able to build the infrastructure. We're also really focused on this data exchange framework that our state is undertaking, and are paying close attention to it, and as well gathering all of your voices to be able to provide, I think, very meaningful feedback into the process. And I think, as we kind of round out to being able to have a draft data sharing agreement, and in this interim phase before we have some true governance, we're really going to be an important piece to be able to provide the state guidance over the next several months. So, I think it's time to really be focused and get our work being even more accelerated. So Robbie, I think I am going to hand it over to you now to introduce our speaker.
I'm happy to. I guess without further ado, we are joined by Amy Miller today with the California Mental Health Services Authority, who will be presenting on their semi-statewide EHR. And Amy, would you like for me to share slides, or would you like to drive them yourself?
Actually, yeah, you go for it.
Okay. Give me one moment.
So thank you for having us today. And I also have my BIP colleague, Dawn Kaiser, on with me as well. So she's the brains of the operation. So I'm the executive director and she runs all the things. So we are here today to talk to you guys about our semi-statewide electronic medical record project. So I think we need to start with people in this room might not know what public behavioral health is. Is that a reasonable assumption for some?
Yep. Yeah, let's start there.
Yeah, let's start. Why are we here and why are we even trying this? So public behavioral health, each county in California operates as a managed care plan serving the Medi-Cal population that is moderate severe. What could be more complicated, right? In terms of, so the mild moderate benefit is managed by the health plans. The moderate severe benefit is managed by county behavioral health. Each county is both a plan, like a managed care plan, and a provider of services. They often operate large networks in order to meet their statutory obligations. So I'm trying to think if there's anything else you want to say about the population we serve. We're funded through functionally a fixed amount of money, which is called realignment. Right now, we bill in the most complicated way possible in the state of California. So we bill per minute with a cost settlement. It's really complicated. Our electronic health record is poised to support counties with a lot of the innovation that's happening as we march towards payment reform. We, CalMHSA, an acronym, California Mental Health Services Authority, are a JPA, another acronym, which is a Joint Powers Authority, a pseudo-governmental entity. So the counties band together to form us, and our job is sort of to innovate in the public behavioral health space and help counties optimize the services that they are providing. We sort of do whatever it takes to help counties do whatever it takes to serve the people that they serve. So I took over as executive director about 2 years ago, and we kind of surveyed counties about, their most pressing needs, and they were pretty clear in saying, we are struggling with data. We can't get data out of our systems. We're functionally managing our business with spreadsheets. And so from that sort of landscape analysis, this project was born, and we've been slaving away at it ever since. So I think we could probably go to the next slide. So I guess this is repetitive. What we call our semi-statewide electronic health record project right now involves 23, sometimes 24 counties. It's got a few teetering on the edge. Right now, it's about 27% of the Medi-Cal population. Our ambition is eventually to be all counties, likely. But this is sort of the first low-hanging fruit cohort of counties that are really eager and ready to move forward. We're, like I said, working towards implementing with payment reform, which is us moving to CPT codes as a methodology of claiming, which happens on July 1st, 2023. So we are on a dead sprint towards that effort. The next slide. We like punch lists. So we've done a lot of things. We've done a lot of convening with our members. We've selected a vendor. For us, our vendor is called Streamline. It's a mid-sized behavioral health vendor. In our ecosystem, there's often a lot of niche vendors in order to meet kind of the demands of our documentation standards. And so the thing that's forthcoming, of course, my newest thing to joke about, the hard part. So getting 24 counties to implement a standardized workflow, standardized forms, and all of the things we have to do. Is the EHR open source? No, it is not. But it is a highly configurable tool. So for us, it's about being web-based and configurable so we can meet our needs as a plan and provider. I love questions, by the way, because then I know if I'm making any sense at all. Next slide. So what we do as the JPA, we have entered into the contract with the vendor. We hold the master contract. We're negotiating pricing, and then the counties contract with us and functionally are buying a per user per month sort of agreement. And we've, for our counties, locked in pricing for 7 years. So we're really basically tier 1.5 support. So after you figured out that your computer's plugged in and connected to the internet, if you still have a problem, then we'll be kind of triaging those things, as well as interpreting state rules. So in behavioral health, we're a little bit unique. Last year, I think we had about 70 rule changes associated with information notices. Those are often very technical in nature that require sort of a codification in your record and subsequent reports. We'll be doing that work on behalf of counties. The list of counties, we are not yet publishing it because we have agreements going through the Board of Supervisors. So there's kind of a little respect issue around not getting ahead of the actual board decision. So by the end of the month, not this month, next month, we hope to be able to publish that list, but we have just a little bit of sensitivity there. Next slide. This is our timeline. So we actually have a pilot phase. So the first 3 counties we're implementing will be going live January 1st. So 3 small counties. Our phase 1 is our main cohort of counties, the subsequent remaining, and we actually don't have any counties signed up yet for phase 2. That is something we had conceptualized, but the value proposition around us doing kind of the thought work for payment reform has been pretty high for counties. So next slide. So I kind of wanted to go over our critical aims, what we're trying to achieve with this project. So the big thing is an enterprise solution. Again, what we're really striving to achieve is an economy of scale to help counties meet their obligation as a managed care plan. So we know that I ran a county before. So I came from Monterey County where I was the behavioral health director. I care a lot about QI and I care a lot about IT, and I could actualize about half of my vision, even though I resourced the project as much as possible. So we're planning to sort of crowdsource and develop an economy of scale so people can actually kind of meet the foundational requirements and then optimize from there, leveraging the data that we'll be able to use. So we're going, because we're nerds, we'll spend a lot of time on outcome reports. Some of my staff that have joined the project have said, do you even want an EHR, or is this just a venue for you to get all the data you ever wanted? Well, yeah, we do want an EHR, otherwise the data would be terrible. So next slide. Crowdsource. So for us, crowdsourcing meaning, pooling resources across counties. So typically counties don't actually work together that much. We pool resources on some things for counties, but often the way it works for counties are each independent managed care plans. They get a new rule set. 58 people sit at their desk, scratch their head, try to figure out how to implement it, and often do so 30 different ways. And so by pooling resources, making strategic decisions, pulling in subject matter experts, our intent is to sort of eliminate that time-consuming waste of counties having to replicate all of these different business processes. All right, and so this is, our PowerPoints are not super fancy. Sometimes we joke that it's not like you're joining a really cool IT firm with CalMHSA. It's like joining a commune or something. Like, there's no fancy brochures. We downloaded this PowerPoint for free on the internet. We spent $0 on marketing. But we've oriented our project around these kind of critical aims that we're trying to achieve. So we're very, very focused on outcomes. Everyone that works for CalMHSA really recognizes that our job is to help improve outcomes for the most vulnerable people in California. And so we know that there's tremendous opportunity by optimizing the EHR, cross-county comparisons on dosage of service, outcomes, type of service distribution. We can expedite learning and bring innovation to scale faster. And that's the thing that we're so excited to do. So that's why we have that as our first bullet. Another important thing for us as counties, we have a lot to do around staff management. That might not seem like a real jazz hand sort of goal, but managing your network and inventory of providers, especially in years like these where people are changing so rapidly, is actually a solution that we really need to bring to scale for counties. Congruent with some of the work that's being done statewide, we're implementing a master consent that leverages some of the thought process that's going on statewide, but will be specific to our instance, will of course be 42 CFR compliant. We are working beyond Medi-Cal, so counties often have different payer sources, such as our MHSA funds, so Mental Health Services Act, the tax on people making over $1 million a year, and we'll be optimizing the solution to quantify those different lines of business and make sure that we're optimizing those revenue sources. And then additionally, we'll be doing a lot around compliance and sort of automating the compliance solution. So in behavioral health, I think people that aren't used to our space would be surprised by how many, frankly, hundreds of things we're tracking to ensure that we're compliant with the Medi-Cal rule set, where they seem to kind of add new rules on every year. All right, next slide. There's a little bit more on economies of scale and collective activism. So we work in collaboration with the state, and so we often struggle with the state at times where they will give different advice for different counties. And so by us working together to write policies, standardized workflows, get those vetted with the state, then we can mitigate risks for the counties and get them more focused on kind of their core outcomes. Right now, behavioral health, we're actually getting more attention than we've ever gotten before. And so that, pushes our need for agility to keep bringing solutions to scale. And so that is what we're intending to do with this aim number 2. Next slide. Another important thing for us in behavioral health that we are redesigning our overall documentation standards. It actually goes live tomorrow, a series of really seismic documentation changes. And for the people in this room, that's kind of a big deal. So many people say like, oh, I want to exchange data with behavioral health. No, you probably don't, because right now our data is not codified. If you say, I'd like to see a chart of a severely mentally ill beneficiary for the last 6 months, you will very often get upwards of 400 pages of documentation associated with that client. In response to the state rule set, we produce just volumes and volumes of documentation that frankly is difficult to read, sort of meant for auditors, not for clinicians. We've been working really hard to clean up that rule set, implement standardized things like the problem list. That's actually new for us in behavioral health, and make our record as codified and lean as possible. So when people like you guys in this room get into data exchange with us, you'll have something consumable and readable. So we'll send over something where the juice is worth the squeeze, which I cannot say about our records right this minute. So future us, starting tomorrow, we start getting a lot better, but we'll be on a journey towards innovating in that space. And then I guess, relevant to this group, we'll be working hard on data accessibility and interoperability. So we'll be kind of helping counties to configure solutions, developing the FHIR APIs, helping them interface with local HIEs, and then setting up, cross-county comparisons around outcomes and data. Next slide. And this is our best attempt at an infographic. So a lot of people don't share data with us. Besides that our record is too big, 42 CFR acts as significant barriers. So often when we think about data exchange around social determinants of health, we think that behavioral health should be at the center because we have the most restrictive rules. And so also many people think of us as like a traditional healthcare provider, but really having run a behavioral health system, when I thought about the work that I did, I would think about these people as my trading partners from a data perspective. So I built out, of course, work around the traditional partners like HIEs, but I actually did a lot of data exchange with schools, right? So the kids that we were serving in IEPs, a ton of work with social services to serve the child welfare population, CalWorks as a specialty population, sharing information regarding the public guardian, homeless services. These are all people that a typical behavioral health system is interacting with every day. And then when I ran a county system, I had staff co-located in these sort of green settings. So the complexity of what we're trying to run is just pretty different than a typical healthcare provider. We spend more time with these other trading partners than we do with primary care or hospitals typically. And so next slide. And we'll skip that slide. All right. And we can, yeah. I love seeing people's faces and actually talking to real people. So I kind of
thank you. Thank you for the presentation, Amy. And I think if folks have questions, feel free to jump in. I do see one in the chat that was earlier, I think from Bill, around facilitating care referrals in coordination with non-county providers. Maybe that speaks to your graphic with social services. Can you explain a little more what that looks like? And is that, referrals and referral management through different platforms, or maybe something more?
Right now, counties do so, frankly, in a kind of kludgy way, right? So they're building out unique or bespoke interfaces in order to achieve that. We think the future looks bright in sort of building that out with closed loop referral systems that are fully automated. It takes a lot to build out a local trust network and data exchange agreements that are HIPAA and FERPA compliant, and how you segment your data. So a lot of work is done in this space. So I don't know if that answers the question, if the person who asked it has more.
Yeah, and I see another question came into around pharmacy. Is pharmacy something you're considering within that ecosystem too?
Yep. That's part of our scope as we're building out pharmacy interfaces for our participating counties. But yeah, you're right. They could actually be a little bubble on our graphic.
Awesome. And Dan, I see you have your hand raised.
Thanks, Robbie. Thanks, Amy. Great presentation. Really do appreciate everything you've shared. Can you speak to what you believe your total patient headcount will be when it's fully deployed? That's one. And can you give us a status as to where you are with consent and your master patient index, please?
Consent. So the same law firm that is developing some of the state's master data sharing agreement and the same staff has worked on our consent. We have a draft we'll be vetting with our members that's largely ready to go. Our EMPI, we're looking, it's kind of interesting because the state's taking on a lot of work around EMPI. So we have that going, but we don't know that that's going to be the full solution moving forward because of some of the other options. What was your third question?
It was about total patient headcount. So I can say in terms of Medi-Cal beneficiaries for which those counties are responsible is about 3.8 million. But as you know, we're responsible for the specialty mental health benefit and also the drug Medi-Cal benefit. So there's, X proportion of those beneficiaries who access those benefits.
I don't know, Robbie, if you can't see my comments, but I've asked a number of questions about interoperability functionality that this vendor provides. I don't see anything about that on their website. Just taking a quick look, I've never heard of these people before. Can you say anything about their interoperability capabilities?
Meeting the business needs of our specialty system is built into the scope of development and will be completed within the next 12 months. So you're right that, the vendor, I think, hasn't spent a lot of time in this space. Kind of many behavioral health organizations nationally are slow to data exchange. And so we are building out all that is required and looking towards a future bend to do as much as we can around data exchange and interoperability. So.
But as you go down that path, be happy to help facilitate connections and discussions, as these folks start to try to build the functionality to connect up to the networks and frameworks and technology that exists.
I will schedule a call with you.
Excellent. And Jim, I see you have your hand raised.
Yeah, I'd love to follow up as well. And I sent a note to one of the Dawns on the chat there. I don't know if I got the right one or not, but would love to chat with you about the governance model and areas we collaborate. My takeaway is that regardless of the particular vendor, you chose one with technical expertise who can build the framework and incorporate and inculcate everything Stephen's referring to in terms of any specific standards or interfaces or workflows, et cetera, as a collaborative product set rather than any one particular vendor's proprietary offering.
Exactly. I just put my email in the chat. Happy to meet with anybody that wants to meet with us. So the marketplace of ideas, we're trying to innovate for public behavioral health. It's a journey without an end point. And we'll keep working away.
And Felix, I see you have your hand raised too.
Yes, thanks, Robbie, and thanks, Amy, for an outstanding overview of this exciting work. One of the first slides that you had up spoke to the need for your members at CalMHSA, the county behavioral health agencies, to not just be service providers, but also reporters of outcomes, which I think a lot of those of us on the call can definitely relate to. It's not just about having a record for the sake of the point of care, but to actually be able to combine and curate data to glean those types of insights that are really important for things like QI and population health. So I'm wondering, as you embark on this process, what the capabilities are that you're envisioning to service that need, to not just, again, like create a record, but to be able to combine it with other sources of information so that you have a holistic picture for that top to bottom analysis of your clientele.
Yeah, so part of it for us in public behavioral health is starting with quantifying all of our unique lines of business. So you think about like the little bubble I had around the justice partnerships. Like in the county that I worked in before, I had 13 programs related to juvenile justice, really with different levels of intensity and expected outcomes. And so for us, we're starting to like do cross-county comparison and quantification of the aims of each of the programs, like how many of them are working towards reduction of homelessness, and then adding that sort of layer longer term into what will be our data lake that will pull in the managed care plan data and then work on our overall outcomes. In our contract with NCQA and our landscape analysis, if you know behavioral health, you know that we don't have a lot of standardized outcomes. There's no A1C for behavioral health, right? And there's really a lot lacking for specialty behavioral health. And so we think that we will be supporting further measurement development that's more specialized to the population that we serve. And then again, the cross-county comparison is going to be a really significant thing for us. I don't know if that responds to your question, but I think Dawn might also have something to say about that.
No, actually, sorry.
Excellent. I see a couple other questions in the chat, and Doug, I see you've got your hand up too. A question from Rita around behavioral health data and how, can you explain a little more around how it's captured, the segmentation exchange of sensitive data handled, and are health and social factor data treated differently?
Mm-hmm. I mean, for us, it's not, behavioral health record is not social data, right? So we are all healthcare providers billing to a healthcare service, but we have to meta tag every element within our EHR as within the 42 CFR vault or without, and then ping it against the master consent to see what we can disclose. So as many of you might know, anything's possible with consent. Absent consent, it becomes kind of a bespoke disclosure protocol. So a lot of work is being done. In the past, counties have handled this in a really kind of kludgy way. They set up totally separate EHRs or even records for substance use versus mental health. So for a lot of counties, this is going to be fairly transformational, just integrating the record and having that unified view just across mental health and substance abuse. And none of us designed it this way because we wanted to. It was really in response to state rules and a complex delivery system, unfortunately.
And then another question, just kind of jumping back to, connections with social care organizations or social services, is a comment from Christine just around, are you looking to like ongoing two-way data exchange with social services to meet the needs you were talking about with like schools and IEPs and justice?
Yeah.
Is that cool?
So one of the lines I often repeat is if we in behavioral health do a phenomenal job, we save everyone else money and spend a lot of ours, right? And so we need to be able to quantify, through some of these external data sources, are we really reducing incarceration rates? Are we getting people into permanent supported housing? So that's why we need sort of this two-way data exchange to help ourselves learn when we're doing a great job, because it's often outside of our record that proves that sort of value proposition. So I think that responded to your question.
Excellent. And Doug, I know you've had your hand raised. I'll give you the floor.
Thanks, Robbie. Yeah, as an RN case manager that struggled with, trying to get patients into these behavioral health programs through the various health plans, it's a struggle. Some of them even want fax forms, which I can't hope that we do away with this faxing system. But the other thing is that, with my medical referrals, I know I have to follow the URAC guidelines. I'm working for the MSO, but and so does the health plan. But what about the URAC guidelines for these behavioral health referrals and some more stringent policies to ensure that they get the treatment and they get the referral source that they need? Because it's mind-boggling that they can get away with as much as they can on the behavioral health side when we have the polar opposite on the medical side.
I think one of the distinctions about our services is that they're voluntary, right? So if you're sitting in an ED, you're like, what are all these people doing with substance use disorders clogging up my ED, right? And I think, as a therapist, I would love it if every single person who had a substance use disorder walked right into our doors and immediately engaged in care and had phenomenal outcomes. That's just not the illness that we're treating. I think we can continue to innovate around closed loop referral systems, and we hope to be a catalyst in which to do so. But the voluntary nature of our services and the complexity of the people that we serve, people often struggling with substance use, mental health, homelessness, a function of the illness that we treat is a lack of insight and often desire for care. There's a lot of work being done in like community-based advocacy, people serving homeless people, delivering socks and doing whatever it takes. But the need, and many of you can attest to, is tremendous. And frankly, our resources are quite limited.
How about a little bit of carrot at the end of the stick? I mean, can we connect it to other resources and encourage them by going to these programs that they would open up more benefits that they could be, enrolled in?
That's what we call case management, and that's absolutely what people do, right? So I use the analogy of socks, which is a true one, but it's also about connecting people to CalFresh benefits and doing truly whatever it takes, helping them navigate through the child welfare system when they're stuck there, helping them navigate through the homeless system or access veterans benefits. So we spend a huge amount of time and effort on case management to help people connect into care. And
I'm looking forward for that case management piece to be connected back to our primary care and specialty providers on the medical side, because we get none of that information.
And I would just also highlight, we're in charge of the moderate severe benefits, where we kind of struggle is a limited window into some of the mild moderate services that exist.
Excellent. And Stephen, I see you have your hand raised, I think maybe for one last question.
Sorry, I just wanted to say that we've had a lot of success. We've been talking about referrals and transitions of care, a lot of success at Sutter using direct secure messaging to support closed loop referrals. We continue to build expertise in that area, and I'd be happy to introduce you to the guy, Christopher Mack, at our shop, who happens to be on the board at Direct Trust, who really understands that as well as probably anybody in the country.
Awesome. Appreciate any linkages. It's definitely a marketplace of ideas. So happy to meet with anyone.
Well, excellent. And Courtney, I see you have your hand raised if you want to just jump in really quickly.
Terrific. Thank you so much, Robbie. Hi, Don. Courtney Baldridge from US Aging. And I have to say, logged on a little late, but absolutely kind of riveted by listening to you, because I hear so many points of alignment between our work. And I think having a dedicated network that has layers of requirement, regulation, specific funding sources and realities in terms of how those things play out, needing to case manage, provide additional services, having challenges, communicating and getting messages directly to clinical providers. I think there's an awful lot to compare notes on. So I look forward to doing that. I've already emailed you all. And I think opportunities for a lot of solutions. I agree with whoever just mentioned Direct Trust. I'm involved in Direct Trust as well. And we're working through the information exchange for human and social services to look at that capacity to empower organizations, and especially the downstream smaller providers that have a hard time exchanging that information in hopes to create that connectivity. So for me, it's really wonderful to see and hear of somebody else that is working hard to try and deal with some of these challenges. So I'll be in touch.
Lots of opportunity here.
Well, thank you so much, Amy and Don, for your work and for your time today. And, please keep us posted. We'd love to have you back to share out again as the work advances as well.
Thanks.
Well, excellent. Well, Timmy, I think I'll hand it back to you.
Great. I think I'm going to actually ping pong it right back to you, Robbie.
Excellent.
And be able to do the readout for the Data Exchange Framework Advisory Group from last week.
Yeah, I guess just to provide a summary of the final stakeholder advisory group meeting, as it's currently composed, was last week. What CalMHSA and Manat did is really walked through what some of the responses to public comments will be, or what we can anticipate in the final documents. They have not released any updated documents since the ones that were released over a month ago. So I think we're still anxious to see what comes out tomorrow. But they did highlight a couple of responses to stakeholder comments and some likely changes. I guess just to highlight a couple, they tried to clarify and revise some of the authorization and consent requirements around 42 CFR Part 2. Previous drafts had kind of suggested that signatories to the data sharing agreement might not be able to share 42 CFR Part 2 data, even if there is an authorization. So they've done some cleanup there. They also removed financial benefit provisions related to the use of information or reuse, and have indicated that they will replace that with language around intent to sell data. So being a little more specific with, when data maybe can't be reused. They also cleaned up the breach notification language. I know that was something that a lot of you have raised, that a lot of the breach notification language went above and beyond state law under CMIA and the Health and Safety Code and HIPAA too. And then I think additionally, they'll be releasing more PMPs for public comment that will be, sort of codified or formalized throughout the rest of the year. We've got a list of those that we can share in just a moment. And that also too, they're going to be making some changes to the digital identity strategy as well. I think responding to a lot of the comments that, many of you submitted to around, clarifying terms and digging into some concepts a little more, considering removing the minimum necessary standard there, and the need for further engagement with social services organizations as well. So, we're expecting that the final data exchange framework and data sharing agreement to come out tomorrow, and the digital identity strategy by the 31st of the month of July. And, I think as those come out, we'll make sure through these meetings and, fact sheets, we can provide, a summary and some analysis for all of you as those come out. Just two other points on the stakeholder group too. They did release the implementation overview of what's next. So, here in the middle in July, they'll be forming a new implementation advisory committee. So we'll kind of see if that looks and feels a lot like the current stakeholder advisory group, or maybe something different, maybe new members part of that. And then also a data sharing agreement policies and procedures subcommittee to help shape some of those new policies and procedures. And then CalHHS anticipates, through statutory authority to create a formal data exchange board that would really serve as in a governance capacity with CalHHS, as well as the creation of subcommittees that would be able to advise on the data exchange board and CalHHS as well. And then I guess just to highlight too some of the policies and procedures that have been identified for development. These were the 6 that they've laid out around qualifying HIOs and defining real-time data exchange. So we'll make sure to monitor those too. But I guess I'll pause there and see if folks have any thoughts or maybe other reflections or other items that they may have picked up on at the stakeholder advisory group meeting last week.
I think, Robbie, just in terms of the advisory board as it is today, that may change in terms of form and function. I mean, I think that's one of my biggest concerns is, what's the opportunity for us to continue to provide input? It'll be directly to John and Lillian, I see you're here, directly to the state, and or will there be an advisory group that will be, have open doors?
Yeah.
And then I think the other question in terms of the PNPs is the development of those and where and how there'll be draft review and being able to get comment back. Was that mentioned at all?
Yeah, they did outline that they they don't believe that the process is subject to the Bagley-Keene Act, but that they will be soliciting public input.
Right.
And that all meetings will be open to the public to listen in as well.
So I think that's, the more clarity we can have around these next steps with timeline so that we can then organize ourselves to be able to be as proactive as possible is going to be helpful. So it might be something for us to talk to them about. Any other major takeaways you all had?
This is Elaine. I just wanted to add, first of all, thank you to everybody in this group. All the feedback and support has been so helpful. And we are spending the month of July doing a lot of planning for these next steps that you're talking about. And it definitely will involve input from all our stakeholders. So first, I want to say thank you, and more to come in the very near future.
Well, thank you, Elaine. It's been a lot of work that's been done under a really tight timeline. So thank you. Any other questions or insight we'd like to share? All right, so we will, as soon as we'll let you all know when the data sharing agreement is published. And then as staff too, we will make a review and then have ready for you at our next meeting, our analysis of that. Robbie, anything to add to that as our next steps?
No, was just gonna agree with Stephen that it'll be interesting to see if the new advisory group looks like the old one. And I think around, monetizing obtained health data, it seems like that's something that the agency and advisory group have been trying to grapple with, is kind of how to prevent some of the reselling of data and monetizing without, I guess, sort of cutting off reimbursement or, potential other financial remuneration. So it'll be interesting.
As long as we recognize that monetization means that the data owner, the patient, gets the money.
Thank you.
Good point, Joe.
Cheers to that.
I guess to just other updates on the budget since we last met. There is a budget deal that was reached with the governor and the legislature. I guess just to highlight some of the health IT highlights. There is, funding for grant and capacity programs for HIE. So this is similar to the proposal in the May revision around small practice grants for HIE. I think we'll see what some of the details around that are. There is also funding for CDPH around public health IT modernization, as well for the EMS agency around their data resource system and for interoperability between EMS providers and HIOs. And also money for HICI for partnerships between community health centers and local public health agencies and HIT training. I guess just to highlight two of the items that weren't included, the Medi-Cal performance payments and infrastructure funding that was spearheaded by the Equity Coalition was not included, nor were the equity and practice transformation grants that had included the ability to use that funding for health IT or HIE upgrades too. So if you like diving into budget bills, we've got that linked here, as well as a floor report from the Assembly. Jim, did you have a question or something you wanted to add?
Oh, yes, sir. Separate but related note, and I'll forward the email to you and to Timmy, but ASTHO, Association of State and Tribal Health Organizations, summarized the HHS bill through the House, which then goes on to the Senate committee for review. But at least in the House markup, it includes about, I'd say in summary, about $500 million extra for public health infrastructure modernization, public health systems modernization. Pretty good chunk of money to be going out to the states if the bill stays reasonably intact.
Great. Yeah, we'd love to take a look at that.
Jim, what's the timeline on that?
Oh, so that's this year's appropriation. So, provided that we don't go through the usual continuing resolution madness of the last 10 years, it will be part of the FY23 approach.
Okay, great. Thanks.
Yes, and Stephen, your comment, I've been thinking the same thing. I think, we'd love to fit some programming in around data privacy and reproductive health, and what are especially our providers and advocacy groups thinking right now. So Timmy and I have been thinking of good speakers for that, but if folks have suggestions, feel free to send them over, email them to us. On that note too, OCR did put out some guidance this week around HIPAA and abortion care and reproductive health as well. And we've got a link in our materials here as well.
I guess I read an article, or at least skimmed through it, that there's also some concerns about PHI claims data, accessibility of claims data, and what that means relative to privacy for reproductive services too, that's causing some concern.
Yeah, the other thing, Jim, that I've been raising in discussions I've been party to is the whole issue of the evolving ability to re-identify de-identified data that's shared. Back when HIPAA figured out how to de-identify data, that was a long time ago in technology years. And I think that, as we think about data exchange, we need to be thinking about both PHI and de-identified data when we think about the potential risks here.
Not to put on my tinfoil hat, but I mean, if you watch, I think it's the Data Brokers on Netflix, it paints for you very clearly that data can be de-identified. Data is routinely de-identified in accordance with HIPAA, provided through data brokers. They match it up with other data sets. They've already been in the practice of mailing out flyers for, oh, we understand you're having a baby, so here's a coupon on a stroller and stuff like that. That's been a legal practice for years, and the government is a huge consumer of those data brokerage services.
Right, and now, of course, lives are at risk on both the patient and the provider side. So I think it changes the whole calculus when we think about the potential risks and benefits of creating data silos, centralized data repositories, et cetera.
Yeah, interesting to see that we're facing the same privacy and security challenges of the third world nation. But
so is this breaking news that the equity and practice transformation grants were included? Sorry, not to go from the tin hat discussion, but
good morning. This is Brandon Bullock with IHP, and I put that in the chat. I'm happy to send the link out to Robbie, but I believe, and this is why it popped in my head, is when I did a search of the floor report, it stated that 700 million were included, but if you actually look in the actual budget bill, in the line item, it only says $70 million is included. So there's a drafting error somewhere in there, but I believe there was these payments at some degree were included in the final budget. But I'm happy to send the line item out.
Yeah, let's take a look at that. Originally, it was 700 million, and 200 million of that was dedicated to the HIE work. So
yeah, I can actually probably speak a little bit to that. Brandon, thank you for also just being eagle-eyed there, looking at the floor report. So a couple things. One is 700 million reflects both federal and state funds that were originally proposed by the department. So 350 million of that would be state general fund. I think the administration had proposed this to be a 5-year, spread out over 5 years. It wouldn't.
Oh, yeah, it was 5 years.
Yeah, so 70 million for the 23-24 budget would certainly make sense in that context, right? Because that's 70 times 5 gives you 350. Second,
so that would include a match.
Yeah,
then,
yeah, exactly. And there could be, I mean, it looks like if that's the case, then that's what's reflected in the main budget bill. But keep in mind that there's going to be additional, what they call budget bill junior amendments that will come out in the coming days to be voted on that are going to reflect the additional changes that were made in the final deal with the governor and the legislature. So it is late breaking, and I hadn't caught on to it myself, and it's part of my job to be aware of these things. So thank you, Brandon, for helping me do my job there.
Yes, thank you, Brandon. I will second that. I completely missed that and wasn't using ampersands in my control finds. So thank you.
Well, this is the power of the collective. So thank you for
Yes.
being on today and
Crowdsourcing.
crowdsourcing at its best. And I think that's great news. So, let's take a look at that and see where and how that might be, considered to be able to be more funding for infrastructure. So let's continue to follow that. Thank you, Brandon. You made my day.
You're welcome.
Okay. Any other questions around the budget? Any other additional? So, one thing that I think we can continue to do is to track this new budget as well as last year's budget on where and how this funding is going to be put towards, being able to benefit infrastructure, data sharing, to be able to support CalAIM for public health, going back to our roots of the use cases, but really helping to highlight and storytell on how this investment can really be made to, instead of one time, to be made where it can really help to build the infrastructure we need in the state. So let's keep looking at this. I'm sure we'll find other opportunities in other buckets.
And at the federal level too.
And at the federal level as well. So let's keep this going. Thank you.
Just another announcement for folks too, and I'll put it in the chat. Our current meeting series has run out as of today. And Kira is no longer with Blue Path, so we've created a new meeting registration for our meetings all the way through the end of the year, through December. So we'll be having one meeting in July on the 14th, and then we'll pick back up with our every other week meetings on August 11th. So if you click the link in the chat and register, you should be able to add all of those to your calendar, and we'll be following that schedule through the end of the year. We'll make sure it's in our news roundup that we send out as well.
And please forward it to others. If you have those that would like to get onto our news roundup, please forward that to us too. We want to continue to be able to make the tent as wide as possible. And let's go to the next slide because I think it's on that. There we go. So we also, I think we're hitting this kind of transition point with the DSA being published this week. We really want to be able to continue the storytelling that we started with our roots last year, both patient stories, provider stories, and all of your stories, how we will be able to benefit and provide value for data sharing. So one idea we had is that if you all have a communications lead or a department that's looking, you have somebody that you can forward to us, that we can then cultivate another community of communication leads. I think that would be really helpful. So that was one of our ideas. And if you could please forward those leads to our communication lead, Steve Maviglo, I would really appreciate that. Steve, I just totally butchered your last name. But if you could do that, it would be great. Steve, do you want to talk to that? I see you're on.
Sure. Just emphasizing what you said. We're actually written a couple op-eds, and we're looking particularly if you have anybody in your organization or patients we can connect with in the Bay Area, the Central Valley, Fresno, Bakersfield, and the North Coast are some of our target areas for the moment. So, but we'll welcome any and all because there are lots of publications out there that are looking for content. And we'd like to provide it with a personal and local angle. So I appreciate it. Thank you.
And Stephen, I see you've got your hand raised.
Yeah, I just registered for the new meeting series and was trying to download it to my calendar. And I noticed when it downloads, at least to the Outlook calendar, it comes in as a weekly meeting as opposed to simply being the dates that you have noted. So there's probably a little glitch there in the way those APIs are working with one another. Just thought I'd mention that in case other people might get caught by that.
Thank you. Thank you for that. We will resolve that after
We thought we had it resolved. Maybe the Outlook put another glitch in the system. So thank you, Stephen. Robbie, do you want to maybe hold on that link then?
Yeah.
Okay. So we'll also follow up with each of you too, with an ask. We'll put it in our roundup. And again, if you could just forward your ideas around communication and bolstering our communications, we'd really welcome them. And with that, I also would love to know if any of you are planning to be at the Civitas annual meeting that is in San Antonio in August. Our panel that we submitted was accepted. Many of you will be joining me to be able to talk about the amazing collaboration we've seen to be able to advance data exchange in the state. So I welcome you to tune in if you, or at least put this on your radar. And also if you could just let us know if you are attending, we'd like to be able to kind of do a meet and greet and put together some type of a small event for us. So put that out there, and I look forward to seeing many of you in person, which will be.
Timmy, I'll just mention, this is Stephen Lane. I mean, I'm going to be there, looking forward to it. Would love to participate in your event. Devin and I have agreed to host an unsession on Sunday afternoon on this whole issue about privacy and security of contraceptive and sexual health data. So if people are going to come in early for the Sunday events, please look for that one.
That sounds great. And maybe we could do, host something social right after that.
Social.
Yeah, and I'll also throw out, I'm doing an unconference event, as I understand it, on the schedule with Mary Kratz from IOI, and Stephen, happy to participate or support you with the privacy security.
Wonderful.
Great. So lots of connections, and let's keep that going. And if there are other events that you all are attending that you would like to, make announcements here, or if we can work with you on creating some one-offs, we'd love to do that. So let's keep the networking going. Okay. Go ahead, Robbie. I'll hand it back to you.
Sure. Just a few other updates. SB 1033, which we've been tracking and submitted a letter of support on a few months ago. This is around health plans collecting demographic and SDOH data on members passed out of Assembly Health and has moved on to the Appropriations Committee. So we'll continue to track that. As was mentioned before, HHS OCR put out a guidance on HIPAA and abortion and reproductive care when HIPAA applies and doesn't. And I think is largely aimed at consumers as well in terms of understanding when data is protected. Cal Matters just came out with another article around data exchange today in the framework and forthcoming mandate with some quotes from state leaders like Dr. Galley and Director Ohanian and others. So I recommend folks check that out too. California Healthcare Foundation had a recent publication come out around funding opportunities for health data exchange and different matches that are available to state Medicaid programs, for example, as well as other social needs related data too. So we are working to try to get the authors of that publication to join us here and kind of dive into that a bit more. And the Blue Shield team has also shared that they'll be hosting an event in July on the 13th in Oakland if folks from the coalition are interested in attending. So please share your events with us. And Dan, I see you've got your hand raised.
Is anybody tracking the CDC opportunity, the $4 billion 5-year public health infrastructure upgrade? I was curious as to whether the state or any of our major cities or counties were pursuing that. I'm not sure Santa Cruz qualifies. I think we're below the minimum, but I'm curious as to.
I believe that's where the public health IT funding in the budget is coming from, but we can confirm that. But
That would be helpful, Robbie. Yeah.
And Dan, you're referring to the Data Modernization Initiative?
Correct.
Okay.
It's probably a grant to the state, and the state's then sending it back.
They said it's going to be 116 awards, so that doesn't necessarily drive. It says county's minimum population 2 million, city's minimum population 400,000. So it's really sort of ambiguous.
Share that in the chat. Do you have a link to the chat? Can you throw it in there?
Yeah, I did read something similar to Dan. Like, I think LA County DPH is kind of separate from CDPH. So we can put, if you could share that link, and we can provide more information on that too.
You got it.
Excellent. And I think that's it. I guess just that our next meeting will be on July 14th. We will resolve the registration link and make sure that gets sent out to everyone.
And we'd love to see you guys on the if you're around in Northern California, in Oakland on the 13th. Robbie and I will be there. So let us know and let's make sure we meet up.
Felix beat me to it. Great job, Felix. The link's in the chat.
All right, we'll follow up on that too. Thanks, everyone. Have a great day, right on time, and happy 4th of July.
Thanks, everyone.
Thanks, Timmy. Thanks, Robbie.
Thank you. Bye-bye.
Thank you, Timmy.
Bye.